Hello, I'm Mally Shansfeld, editor of Endodontic Practice US, a MedMark publication. Welcome to a live presentation and question and answer with Dr. Fernando Meza. In our webinar today, we will be discussing implementation of laser-assisted endodontics with understanding and confidence using the EdgePro for initial root canal treatments and retreatments. Before we get started, I would like to invite viewers to use the chat box on the right side of your screen to ask any questions, and your questions will be answered at the end of the session. Also, associated with this presentation is a free CE quiz. 1 hour after the end of the webinar, we will email all attendees the presentation replay, along with a link to access the CE quiz. Now I'm pleased to introduce our guest for today. Dr. Fernando Meza is a graduate of Vanderbilt University, where he received his BA in psychology. He received his DMD from the University of Connecticut School of Dental Medicine. After graduating from dental school, Dr. Meza went on to receive his specialty training from Temple University School of Dentistry, where he obtained his certificate in endodontics. During his residency, Dr. Meza conducted research using the BioLace Erbium Chromium YSGG laser to investigate its effectiveness in disinfecting root canals. The promising results of his research led to a publication in the Journal of the American Dental Association 2007 issue. Since 2004, Dr. Meza has been practicing endodontics in Northern Virginia. In addition, Dr. Meza has been awarded Top Endodontist by the Washingtonian Magazine in 2013 and by the Northern Virginia Magazine since 2009. Dr. Meza has been recognized as one of America's top dentists since 2011 by the Consumer Research Council. Dr. Meza, we turn the webinar over to you to learn more about our topic for today.
Well, thank you very much for the introduction. I'm very happy to discuss today what I've been learning or have learned in the last almost 5 years here using lasers in endodontics. And so I'm excited to give a course here or a webinar on the EdgePro unit, which is a 2-watt laser unit, and it's mainly used for enhanced irrigation within the root canal system. And as you'll see here, I've used it for many years now, essentially for root canal treatments initial or even retreatments. And I'm happy to discuss some of the kind of new insights that I've had over time with lasers and endodontics. So let me get started right away for you. So my practices, I have 2 office locations, one in Arlington and one in Alexandria, and hence the name. And we recently changed the name to add laser to it. So it's really Arlington, Alexandria Laser Endodontics. And we're just in Northern Virginia, outside of DC. And so let me get to it here. So first, just a disclosure, I'm a key opinion leader here with Brasser USA. And a lot of what I'm discussing here are kind of my own opinions of treatment. By no means are they fully implemented protocols, so to speak. They're safe protocols in that, and what I've used clinically and during my essential practice, during in day-to-day clinical practice. They're safe protocols based on other protocols that have been around for some time. But so I'll just mention that briefly. Here's some disclaimers as well. And if you can read those through here. Okay. All right, so let's get started. EdgePro basics. So the unit has essentially 3 different protocols, and it also has an endo geek mode, which we'll discuss, and I'll show you a video on. But essentially, you've got your water endo protocol. And what that does is you actually have water coming through the handpiece. So you're actually supposed to prime the handpiece prior to using this protocol. And we'll be diving into some of these and the settings in a few slides. Just to give you another protocol here available on the EdgePro is the solutions protocol. And that's what kind of is an external water source or solutions, meaning that in this particular sense, for the most part, you are turning the air and water off of the handpiece, and you're just providing solutions through a syringe. And the syringe can be anywhere. It could be a 3 ml syringe or a 6 ml syringe or even a 12 ml syringe if you so want to do that. And then, of course, we have our hybrid technique, and that is the protocol that kind of does all of the above and kind of mixes some of the settings for you already. In addition to protocols, we should be discussing irrigation modes. And for that, I mean, even if you go back to ultrasonic irrigation or you have what's called continuous irrigation and intermittent irrigation. Those are two different types of irrigation modes. Okay, well, we're going to do the same thing with lasers, and I'll just discuss them briefly for you. But continuous, we have DA for dental assistant, pretty much required uh, if you're doing this type of irrigation with solutions, which we'll discuss. But if you don't have if you're not working with a dental assistant and want to do a type of continuous irrigation, you can use the water endo setting, and that basically has water going through the handpiece. What that means is that you're activating the laser energy through the fiber tip, and you're also getting water delivered at the same time. Intermittent is essentially provider only required, since you're essentially putting solution or water or saline into the pulp chamber on your own, and then you're activating it separately without any continuous delivery of that solution. Okay, then we have what is called the hybrid technique, and the hybrid technique would be a combination of continuous irrigation and intermittent irrigation throughout the procedure. And in that case, again, it's pretty much necessary to have your dental assistant help you with continuous irrigation if you want to do it properly. But intermittent irrigation is something where the provider alone can do it. So moving on here, here's a video and a photo that displays basically continuous irrigation. And I like to usually use solutions such as 3 to 4% hypochlorite when I do this, and I'll start the video now. As you can see, we like to use also something called opal dam, and that's what we put around the tooth so that we can seal it properly. And you can see that the syringe is being delivered, the solution's being delivered and suctioned nearby all at the same time. And that's a version of continuous irrigation. As I had mentioned before, if you use water endo protocol, you can envision that the handpiece itself is delivering water or saline, and then you have your assistant providing the suction. In this case, your assistant is also providing the solution, and that's why I had said that prior in the prior slide that a dental assistant's more or less required for this in order to do it properly. All right. If you noticed in that photo is I have a technique here where I'd like to bend the needle, irrigating needle at the very end of the tip. And if you do it correctly, you'll have a little 5 millimeter bend there. And you can apply that bent irrigation needle, and in this case, it's a 27 gauge side vented irrigation needle. You can apply that to any size syringe that you prefer. I typically stick with either 3 millimeter or a 3 ml, sorry, and 6 mLs, and then we just replenish the solution as needed throughout the treatment. So we've discussed different types or modes of irrigation: the continuous, the intermittent, and then of course the hybrid, which is both. And I use both, basically the hybrid approach, during my root canal treatment, and we'll go over some of the cases later on and some of the slides that show this. But let's go into the tips now. We have the EdgePro tips. You have 3 tips. Tip 1 is a 200 micron diameter tip, and it is a conical tip at the end. In fact, all tips for the EdgePro are conical tips, meaning that they actually, when the laser energy is deployed, it's deployed as what looks like a donut shape. And the reason it's a donut shape is that it's not end firing at all, at least for tip 1 or 2. And what you see is the donut without any light energy going directly at the end. And so these create radial firing emissions essentially once you depress the pedal Prior to that, once the laser is in ready mode, you will see an aiming beam as such here on the upper right at the end of a handpiece. So it's very important to make sure the aiming beam is a nice, robust, and visible prior to testing the laser by pressing the pedal into, say, a pulp chamber that's flooded with solution. We'll go over that in a little bit. But let's discuss tip one. Tip one has what's called a 55 calibration factor. That means that actually the energy output is about half of what it says on the screen. And the reason for this, it's imagine trying to put a garden hose on a fire hydrant. As much as you can adapt to it, there's only going to be such a limited amount of water going through that little tiny garden hose, even though the fire hydrant could potentially deliver more water. And so that's what's happening here. The laser energy is just being decreased essentially as it tries to make it into a smaller tip, such that you lose about 55% of the energy coming through. Not to matter too much, but just to be just to know what's happening here. For example, you have an EdgePro setting 25 millijoules. Your output is 25 millijoules times 0.55, and that's the 55% calibration factor. So ultimately speaking, you're actually getting an output of 13.75 millijoules. I like to think of it as just half. So basically, it's approximately 12.5. Now, on the bottom of the screen here, I've laid out a typical range of output energies, taking into account the calibration factor that are often seen with tip one. Okay, so that's tip one. I recommend only a single use for tip one because it's fragile, and what you don't want to do is keep reusing tips to the point where you get backscatter into it, which could happen as they're damaged at the end. You get backscatter into the mirror. That's the top portion of the handpiece, and then it can damage the mirror. And once the mirror is damaged, then you don't get as much energy going into the fiber tip. So that's the recommendation for that. Okay, so the reasons why you like this tip, and this is, I laid out some of the reasons, good and bad. This is what I've come up with over time. It certainly does fit into smaller canals. It's applicable to conservative canal preparations, and the pre-settings that are already coming in on the EdgePro unit can kind of remain as is. And the reason for this is that if you're working at 25 millijoules, while that might be a little bit strong for, say, tip two that we'll talk about, or tip three that we'll talk about in the next slides, it's going to be half the energy. So it could be that even though it says 25, you're actually outputting 12.5. So those are the reasons you may like this tip. The reason you may not like this tip is there is a higher ledging potential with this tip, and the reason is that it's very high energy dense. Imagine as much energy as the 12.5 millijoules outputting going onto a very, very small surface area versus tip two or three, which have greater diameters. Their surface area where the energy is emitting is much larger, and so therefore it's not as energy dense and therefore not as likely to create a ledge for you. The other reason you may not like the tip is maybe the cavitation effect just for the chamber is not strong enough. It may be good enough for the canal, however, for the chamber, it just may not be strong enough. In this case, you have some options, which is basically increase the millijoules or simply maybe switch over to tip two, keeping the energies the same, and in that case, making adjustments to decrease them as well as needed. So let's move to tip two. Tip two, as you can see there, it's a little bit broader, and you can see the aiming beam. The diameter is actually 320 microns, and in this case, the calibration factor is 85%. What that means is that, again, I'm going to equate it just for easy calculations. It's just about approximating a 1, right? So the example here, again, is the EdgePro setting of 25 millijoules. The output is 25 times 0.0 times 0.85. That's the calibration factor. Gives you 21.15 millijoules, or approximately just 25 millijoules if we just kind of think in our head it's just a 1-to-1. In this case, you'll notice that the typical range of output energies is a bit higher than tip one, and I've listed those down below. Reasons why you may like this tip, it's very versatile. It's used both in the chamber and in the canal. Less ledging potential, of course, and that's because of the lower energy density. because of the broader tip. And I like to think of it as a one tip solution for the entire treatment. Whereas, tip one may not be strong enough for your chamber. Um, this tip can be strong enough for your chamber, the cavitation effect. And then as long as you keep it potentially in the orifice or just mid-root, which is where we recommend tips to go anyways, you'll find that the tip is robust enough to create the cavitation effect that you want. And in several cases, decrease the energy slightly as you go into the canal, just because it's too strong. So, that's why, and that's some of the reasons you may not like this tip initially, is that the first time you put it into the chamber, the reading on the energy that you're used to with tip one may just be way too strong for you. And so that's where you really want to start to understand some of the cavitation, laser activated irrigation concepts, and try to make adjustments. So it kind of calls on you to be more understanding of the laser and the unit that you have, and not just following a recipe or a protocol. And that's one of the aims of this lecture for you, is to try to give you some understanding so that you can use the laser with confidence. So reasons you may not like the tip: it may not fit into smaller canals, the energy output's too strong, and it requires you to make adjustments for desired cavitation effect, meaning they're just too strong. You just bring the energy levels down. Okay, so all right, so moving on here, tip three. This is the last tip that's available for the EdgePro. It's a calibration factor of 95%. And I like to equate it as one as well. So getting closer to that one. Um, and give the example again of the 25 millijoules. It's going to be, 25 millijoules times 0.95 equals 23.75 millijoules, or approximately just 25 millijoules. Now, in this one, because we're getting at 95% calibration, you'll notice that a typical range of output energies are a little bit higher, even in the range of 14.25 to 71.25 millijoules. Reasons why you like the tip. Again, versatile, used both in chamber and the canal. It does not ledge, even larger surface area, and therefore decreased energy density where for the target tissues. Can be used in teeth with limited access. That's one really good perk about this. Oftentimes, as endodontists or specialists, we're called to do second molars, where it's difficult to get a tip into the canal, into the mesiobuccal root, for example. This is a tip that's very nice to get into at least just the orifice, and always make sure that when the tips do go into the canal, that they're always loose. The other thing to remember is that we do like to just keep them at the mid-root or the orifice level as we do our laser activated irrigation. Another interesting advantage of this tip is it can be used for desensitization and debriding of the sulcus or sinus tracts. So oftentimes we can just place this tip. Now, in this case, you do want to use water through the handpiece, and that's for the sinus tracts and the sulcus. When you're desensitizing, you actually want the air and water to be off. And I have a separate lecture on this that is used quite well in teeth that are just really hot, and you've given enough anesthetic, and you've given supplemental anesthesia, you started the cavity of the access prep, and you still can't get into the tooth. It's a great way to turn to this tip for desensitization, so that then you can use a burr to access the tooth and then do an intrapulpal. Size of this tip is 500 microns. And reasons you may not like it is, again, maybe the size is too big. It just won't fit into smaller canals. It is kind of limited to the chamber and hovering over or placing loosely in the orifice, and that's just fine. Sometimes just doing that is enough to give you pretty nice cavitation effect throughout the tooth. Another reason is it requires you to maybe decrease the energy because the effect is too strong, but that's a simple of dialing down the energy. So it just makes you do a little work that way. We mentioned maybe this is limited to the chamber. There are other laser units out that pretty much kind of just do tips in the chamber, and they do quite well. The beauty of the EdgePro is that you have the ability to do this with tip 3 and 2. But then you also have tip 3 and 1, I'm sorry, tip 2 and 1, to be able to place pretty much almost anywhere in the canal, although we do recommend the mid-root and the coronal area as long as it's loose in the canal. So that's another beauty of the EdgePro, is that you got full control of photoacoustics. Place it in the chamber if you like. Use a lot of hypochlorite in that type of technique, and then it's almost like thinking of a gentle wave unit where it has its pressure generating unit up at the top, which is the laser energy, and you're just dumping, milliliter after milliliter of hypochlorite solution continuously, and then having your assistant apply the suction around it as well. And then, of course, we have the tip in the canal, and that's just another way to that this EdgePro unit is so versatile. Okay, so some of the presets, just so that you get familiar. Water endo protocol, I've listed them here. It starts with a pre and post rinse, and you'll notice 75 millijoules at 1.5 watts over 20 hertz, 20 air, 90 water. Then we go into a water setting, and then a dry setting, which I don't use at all. You can just use the pre and post rinse. That's going to be just limited to your chamber, because look at the amount of energy coming through. 75 millijoules is pretty strong, and that's a situation where I think chamber only works the best, and there's going to be a lot of splash, and in that case, water is probably the best way to do it. If you wanted to do it on your own at this high level of energy, you could do it in the chamber, but you'd have to have your assistant give you the water or saline through a syringe. And in that case, your air and water would be zero, or set to zero. The water protocol is meant to be going into the canal themselves, in which case you'll be using tip 1 or 2, typically. And this allows you to use this and get a nice a debridement, cavitation, flushing out all at once through a continuous way. And then you can, that can assist you to do your instrumentation in between and flush things out. The beauty of solutions, as we start talking about that, is because now we're getting into more chemical type of treatment, which is, part of what root canals are all about. It's a chemomechanical instrumentation or chemomechanical method of clearing debris, dissolving tissues, dissolving bacteria. And so just think of the laser here as adding just agitation or even heat, as I'll describe a little later with intermittent irrigation, and just priming your solutions to be more effective and more efficient. And so in these cases, you've noticed that we've dropped our millijoules significantly. Part of the reason for this is we don't want additional solution to kind of splatter out of the tooth too quickly onto the patient bib. And you also want it to be in the tooth as are activating the laser and continuing on this cavitation effect. Okay, so you have 3 different settings for that, and they're all pretty much the same here. Solutions 1, solutions 2, and 3. And we do recommend that typical sort of sodium epichlorate first, EDTA second, and then sodium epichlorate at the end. And they all have the 0.75 watts over 50 hertz setting. And as we'll talk very soon here, I'd like you to pay attention at the hertz. That's the 50 hertz here. We'll talk about hertz that are lower and higher. We'll talk about what that means in terms of frequency, whether it's low or high, and the benefits of that. The last setting here is the hybrid setting, and that's a combination of the two, and that's pre and post rinse at 75 millijoules, as noted here on the slide, followed by solutions. Now, solutions here, you'll notice that they've upticked the energy from 15 millijoules to 25. But you also notice here, now that as we start talking more about the frequencies or the hertz, they're still at the 50 hertz level, and that's what I would consider like a higher hertz setting, okay? All right, moving on. So here it is, higher hertz versus lower hertz. What does this all mean? Well, we're going to recommend you do a little experiment here with an extracted tooth or a model tooth in just a little bit. At some other time, but there's slides here to tell exactly how that's going to happen. But essentially, you have in higher hertz, lower hertz. I like to think of it as higher hertz are like little jabs, and what that means is it's gentler, sustained pressures, more mixing and scrubbing, and you have what's called and that's essentially a high frequency setting. High frequency meaning that they're 40 to 50 pulses per second as you set it up on the EdgePro unit. When you have a lower hertz situation, you're actually going to feel on the extracted tooth with your hand, you're actually going to feel more the vibrations or the pounding of the pulses. And I describe it more as a pulsatile pounding, a breakthrough energy, perhaps, maybe as we're dislodging tissues in the canal or opening up into isthmuses. And in this case, it's a low hertz situation, usually in the 20 hertz range starting out. You could go 15 hertz as well. 10, I don't really use much, but I usually go with 20 and up it to 25 perhaps. But 20 is sort of my starting point in terms of low hertz. And then 40 hertz is sort of my starting point for the high hertz situation. And in this case, we're comparing little jabs to deep uppercuts. And that's kind of how I think about it with the lower hertz situation. We're going to go into why these are important and why they might make a difference in the tooth and maybe in the sequence of our protocols. So here's the experiment. We want to take an extracted molar or true tooth model of a molar. You want to access the molar for root canal therapy. You want to flood the chamber then with water or saline up to the occlusal surface. And then you want to check for any leaks from the apices, add glass ionomer or cavity, add glass ionomer to plug up leaks and more liquid if necessary, of course, if some's leaking, but if you got to sometimes add that glass ionomer there. Then you hold the tooth in one hand, you place a laser tip inside the chamber, and then you fire the laser. And this is exactly what I've done here. And just to give you, I'll play a video here in just a second, but just to describe the slide, we're going to be comparing first a low frequency setting, and that was set at 50 millijoules, and that was 0.5 watts over 20 hertz. And then we upped it to essentially 50 millijoules at 1 watts over 40 hertz for the higher hertz situation. So let me just go ahead and play that video. Now you can hear a little bit of the snare drum, as you can hear the higher frequencies. Okay, let me play that again just real quick for you. But initially you're hearing the low frequency at the sort of bass drum. You can hear that it's less of them. And it pounds a little bit more against the tooth. You can feel this with your fingertips. And then the higher situation, higher frequency. And here there's a lot more of the pulses. And this is more of a gentler sustained pressure. And what's interesting here is that the energy is the same. So, all right. So anyway, moving on here. Just pointing it out that you sort of switch from the 20 hertz to a 40 hertz, and that's low frequency versus high frequency. All right. Here's a video of exactly this inside of the tooth now. So let me just show you how that works out. And we start first with a low frequency. And this is a tip 1. And we'll talk about more choosing your energy starting level. And that's when I like to say that about 90% of your solution stays in the chamber. If more of it comes out, then you have to decrease your energy. Now you can see already as we're adding syringe irrigation how much tissue is coming out of the tooth, despite, instrumentation initially. And this is what's nice about combining the laser with your instrumentation is you're removing things mechanically initially, but then you're activating solutions with the laser to see if you can loosen some other little small tissue tags or areas. So at this point, we've begun to switch over to high frequency. And what this does is the high frequency, in my opinion, is more of a gentler sustained pressure. And as we're doing this in an intermittent fashion, you also get increased temperature of the solution. And it's even higher temperatures than you would on a low frequency because you're actually essentially doubling the pulses in the same second, from going from 20 pulses to 40 pulses. So that's actually what's happening there is less thermal relaxation and more pulses of energy, and consequently heating up your solution a little bit more. And I think that's beneficial. I think that's beneficial to heat up your solution within the tooth. And this is where I like to use my Triton solution as well, the intermittent phase of this, and we'll go over that a little bit later too. So choose your energy. What does that mean? I just was talking about it. What that means here is that you don't want what's happening over here on the right side with the tooth and the splashing. If you put your laser tip into the pulp chamber and you flooded it and you instantly get all this splatter coming out, my opinion, the energy is just too great for this tooth. Yes, that's true that you could kind of get around it by using a continuous irrigation mode, whereby your assistant is continuously delivering as it gets splashed out, and then trying to suction whatever's getting splashed out at the same time. I think that it's just too strong, and I think that what happens inside the tooth is you dissipate that solution too quickly, and you might even go dry at some points and inside the tooth, and that could create little burn marks in the tooth, potentially in the chamber if the energy is too high. So we want to make sure that our laser tip always has some water. It's submerged in solution or water or saline as it's applied to the chamber inside the tooth. So we don't typically use the laser in a dry mode inside the tooth. And so if it splashes out too much, this is where you just decrease your energy, and to the point where about maybe 90% of the solution stays within the chamber. That's usually a good starting point for your initial energy. And so I have a video here of how that's done on the EdgePro unit. I'll play that now. And I do like to start with low frequency first. And what's interesting about and great about the EdgePro unit is it adjusts your watts accordingly. So you don't have to think too much about having to adjust the watts first and versus the hertz first. Once you arrive at your energy that you like, and let's just say that's 20 millijoules, then you have you can adjust the hertz to get down to your low frequency setting, which is what I'm going to show you right now. Now we start it here. Stand by ready. You can see that we're at 20 millijoules, and all we did was just go up and down on our hertz, and we established a low frequency setting. This would be the one of the important settings for you. If too much splash was occurring in the tooth, you would simply just decrease your millijoule to 15 perhaps, and then you'd go from there, and then you'd usually go to 20 hertz, and then again your watts would adjust accordingly by the unit itself. So and this is what we were just talking about. So once you set your energy, maybe your step two is you think 20 millijoules is going to do it, but what you do is you want to make sure that the red aiming beam is visible on the patient bib, and then if it is, then you flood the pulp chamber with desired solution, place tip 2 in the chamber, or tip 1, whichever one you'd like to use, and then we press the pedal to activate the laser. If 90% of the solution stays in the chamber, that's a good energy to use. Let's assume that was 20 millijoules as we did in the last slide. If it doesn't happen that way and most of the solution comes out of the chamber, then you know that 20 millijoules is just, or it's just too much, and you got to decrease the energy. All right. So step 1 and 2 kind of go hand in hand. Once you figure that out, then I'd like you to try to figure out your low frequency setting. And then once you figure that out, then we go to step 4, which is, choose your high frequency setting. So you'll notice here that we have equivalent energies in the 20 millijoules that are provided here. except that one's got the 20 hertz and as the low frequency, and the other one's got the 40 hertz at the low frequency. I like to use low frequencies for coronal conditioning with solutions or continuous irrigation while instrumenting. Once I'm completed with my instrumentation, I do like to move to the intermittent irrigation with solutions, and I do like to change it to the high frequency settings, in which case we've completed instrumentation and now we're just focusing more on disinfection phase. And just to kind of bring it back, tie it back together, the lower hertz is more of that pounding, pulsatile, breakthrough energy. The higher hertz is more of that gentler push, that more sustained, push, and it's more the mixing and the scrubbing. It's sort of like your fine sandpaper after you've gone through your coarse sandpaper with the lower hertz. And there, just to point it out, the difference, the 40 hertz is the high frequency, but you keep your millijoules at the 20 millijoules. And if it's not 20 millijoules because it's too strong, then you increase it or decrease it for whatever you need for the tooth or the case. Here's an example of how we're switching from the low. Once we found our correct energy setting, this is an example of how I then can just switch easily to a high frequency setting by just increasing the hertz. So I'll play that video for you now. So we still adjust our energies. We bring it back to what we liked, which was 20. And now we want to increase our hertz. And you can see that the watts are just basically being adjusted for you. And that's it. You basically have now your high frequency setting. So just to recap, choose your energy first. That's dependent on the tooth. I like to start with 20 millijoules, and I like to start with my low frequency first at 20 hertz. If the water splashes out too quickly, that means that the millijoules or the energy is too high. So decrease that down to 15 maybe, or 10. And then, or maybe you're just, maybe tip three or two is just too strong and you need to use maybe tip one, because remember that decreases your output energy by half. And so go with that. And then, of course, once the energy is established and you got your low frequency setting, use that for continuous irrigation with solutions, is what I like to do. And then once you've finished instrumentation, then you move on to the high frequency setting and you use more intermittent irrigation, and that's more the scrubbing at the end. And then we'll discuss later, but I like to finish it off with a final rinse of saline at the low frequency setting with about the same energy or slightly higher energy. And we'll discuss that in a little bit. Just a reminder in terms of what energies are acceptable for the canal and the pulp chamber. I generally like to think of the canal, which is listed in white here, as energies that fall between 15 to 50 millijoules. The 50, I'm kind of moving more towards the coronal aspect of it. The 35, I feel very comfortable using that mid root. And 40 and 50, I'm kind of thinking more, I'm moving more coronal. If you use 35 at the apical, which we don't typically recommend, you have a greater chance of ledging because the energy's maybe a little too high. That's where you're kind of thinking, if I'm going to put my tip more apically, maybe I'm going down to 15 millijoules or 25 millijoules. So it's just one of those things where be conscious of that. Of course, if we're using saline, maybe we're not too concerned about a possibility of extrusion, but in addition to that possibility, which doesn't really occur or I have not heard of that occurring, at least in my hands, you can, patient will feel vibrations, and that might be a little sensitive for the patient. So in that case, if you kind of defocus and come back to the orifice or the mid root, or even just decrease the energy, those are sort of things that should be in the back of your mind when you're using the laser. In the pulp chamber, we can use higher energies because the surrounding volume of the pulp chamber is much larger than a particular canal space. And so here you may just require higher energies, and those can come at 75 millijoules or 100. Of course, we're teaching you here, at least I'm teaching you, to start with 20 millijoules and see how that goes for the chamber. And that might be enough for both chamber and canal. So, and you'll see that most of my energies are kind of on the lower end anyways. But this is a good slide to kind of give you an idea of the range of the tips. Tip 1, tip 2, tip 3. And I know we've been talking about a lot about millijoules, but it's simply this equation here on the right there, which where the handpiece is, and it's joules equals watts over hertz. To get millijoules, you just simply multiply the joules by 1,000, and that's how you get it. All right. So I like to talk about the last frontier in the tooth. I feel like a lot of emphasis has been obviously on the main canal. And of course, yes, we got to find our main canals, we got to instrument them, but we also have to remember that there's additional features inside the canal or elements, and those come at you in dentinal tubules, lateral canals, isthmuses, apical ramifications. We can kind of lump these into accessory canals and isthmuses. And I believe this is kind of like the last frontier in the tooth. I think the focus now can very well be these elements, and I think that's what we really need to be focusing on at this point. And I do believe laser is it will be, I think, eventually capable of really cleaning these elements in the tooth to as we keep modifying our protocols and improving our techniques. But I think laser activated irrigation, lasers in general, have a real promise in being able to tackle the last frontier in the tooth that I like to call. So we just mentioned this, but there is a clear difference between accessory canals and isthmuses. An accessory canal is any branch of the main canal that communicates with the external root surface, and an isthmus is an internal communication between canals. So we have some classic studies that demonstrated that these are present within teeth, and the roots are not as simple as we make them to be. They're actually very complex root canal systems, essentially very complex in that we used to think there was maybe 27.4% of accessories in canals according to older studies, but now modern day studies have shown that accessory canals are present in close to 75% of teeth, and micro CT studies have shown them to be present within even 68 to 77% of teeth. And so while our classic studies may have pointed to a lower percentage of these accessory canals, more of the modern studies with better technologies have actually shown to be a lot higher percentage of the prevalence or presence of these accessory canals in teeth. And for the most part, they seem to be mostly found in the apical regions of the tooth. And that's and here's some isthmus sort of studies as well, because those were about accessory canals. But isthmuses here, and these are more recent kind of studies, show what's the prevalence of isthmuses. And Wolf found that in maxillary second molars, there was a connecting canals, is what he called the anastomoses or the isthmuses, and those were coming at 16.3%. And another study, mandibular molars, in the apical 5 millimeters, isthmuses were found to be even as close as high as 85%. So these are real anatomical features that we really need to pay attention to that can mean sometimes the case, not working out for us. And so I think that we just gotta focus on some of these elements at this point in time, and not just the main canal. And how nice can I get a weight line down to the apex? I think we really need to figure out if we can clean these features or elements a little bit better. And I think lasers again can allow us to do this. I like to think of lasers, I like to think of root canal treatment in 3 phases to break it down. And I think the last frontier is more sort of like, the dentinal tubules, lateral canals, and isthmuses. But let's not forget that isthmuses are present, not just at the apical regions, but also in the main canal towards the coronal as well, and also present right at the floor of the pulp chamber. So that's why isthmuses is kind of broad reaching here, showing you the three phases of root canal treatment, but let's just quickly go over them. First, there's debridement. That's number one. And of course, you want to debride your necrotic and vital tissue. Of course, there's organic and inorganic debris, and then smear layer created from our files that we use to remove dentin as we instrument. And secondly, we are then, of course, what I like to call bulk disinfection, and that's the main canal and the apex. And then let's not forget our deep disinfection, which is what we're maybe not focusing as much on, but now with lasers, I think we're going to be discussing these a lot more in the years to come. And that would be deep disinfection of your deltas and lateral canals and isthmuses. How far do I go down the canal? To tackle these, well, we have for phases 1 and 2, it's chamber and coronal third to mid-root. This is with your laser tip. And dentinal tubules is going to be mid-root to apical third potentially. In this case, maybe tip 1 is the only one that can do it for you. Be mindful of lower energies at this point and percentage of solutions, thinking maybe I can decrease my percentage of my hypochlorite solution perhaps, or maybe decrease my energy if I'm really trying to go more apically. However, good evidence from clinical studies as well as case reports of cases have shown that mid-root placement of the root actually delivers quite a robust cavitation force at the mid-root where the tip is, and also down apically further from the tip. So I think mid-root positioning is quite good. Which tips do I use? Well, right there we have tip 3, tip 2, tip 1, and that's for the chamber and the coronal. And the mid-root, and then tip 2 and tip 1 for the mid-root to apical. All right. Interestingly, just wanted to make a comparison here of not just the cavitation effect, but also the streaming or the fluid movement that can occur with lasers. Just as a comparison, ultrasonic activated irrigation has been measured with fluid velocity studies to come around 0.15 meters per second to almost 0.33 meters per second. This equates to almost a 1 mile per hour, I think, rate. And that's why I have this girl just kind of very, very casually, slowly walking. And that's kind of meant to represent the 1 mile per hour. Now let's move over to laser activated irrigation. Speed of fluid movement is almost 22 times higher if you consider from 0.15 meters per second to about 7 to 10 meters per second. You're actually thinking more not just a very, very casual slow walk, but almost like riding a bicycle at pretty high speeds. And what this allows for is much faster fluid flow in the tooth, and the ability to also promote powerful, robust cavitation. Ultrasonic activated irrigation, unfortunately, creates weak cavitation forces, and as we see here, very low fluid movement. So our acoustic streaming is quite low compared to laser activated irrigation streaming. But what's also most important about ultrasonic activated irrigation is that the cavitation effect is very limited inside the canal. And this is because a lot of the canals don't initially come very large for the space to be inside the canal to oscillate properly to create the cavitation forces with ultrasonics that are noted in studies where they've placed the ultrasonic file in a larger reservoir or a larger prepared canal. We're dealing with canals that are either prepared smaller, more conservatively, or just smaller to begin with. And so you don't lose this ability to create cavitation with the use of laser activated irrigation. So just to compare the two differences here. So I have a middle mesial canal treatment that I did here for you. And here's showing some mesials here. And this is after some instrumentation and some syringe irrigation. And I've been using the laser throughout. I'm going to show you how much better it looks here with some, after instrumenting a little bit more, with some of our intermittent irrigation here and laser activated irrigation, of course. And that was tip 2 that we're using inside. Now some syringe irrigation to flush out some of our debris. And now we were then doing some more intermittent irrigation here. You plug the canal first, and then you activate the laser tip. And you can see that now we have to kind of go back and forth between the syringe irrigation and the activation of the laser. And as you remember before, I had said this provider can kind of do this on their own. It's exactly what's happening here. I do have my assistant next to me that's helping me, but I don't require the assistant to simultaneously be delivering any solution. You can see this is the Triton all-in-one solution. You can tell because it's a little bit more bubbly. I don't know if you saw that real quick, but that's the suction just kind of took down that the solution that was in that middle mesial. And we can tell that it's a lot cleaner at this point than it started. And so that's an example of intermittent irrigation. I'm going to continue the next phase of this video. And now we're using BC sealer to fill our canals. You can tell that some of the sealer, because you clean so well, some of the isthmuses and some of the debris real well with laser, you can tell very nicely here how clean the floor and the canals look, and how well the sealer adapted into the canals, and how it even flooded into some of the canals from a different orifice. And now, of course, we're just obturating the case. I use single cone obturation, and in this case, just like that. See, we're just condensing the gutta percha now. And in this case, this is our, going to put an orifice barrier here on it, but we're just suctioning the fluid here. And this is the case here. And also the pre-op CBCT. And now we're just adding an orifice barrier onto this. You could see on the pre-op CBCT the how wide this tooth is from buccal to lingual on the mesial roots, and you can clearly make out a middle mesial canal in this case. I knew that ahead of time going in, and we're making out some of the periapical lesions on the CBCT of the case, which were somewhat present also on the periapical image that you see, but maybe not as not as apparent on the CBCT. And so this case was a partial necrotic case. You can see we got probably a little lateral canal there on the distal root as well. So let me point to you now, sort of my latest protocol, or sort of a busy slide here just to give you an agenda of it, but let's follow through the slide, going from numbers 1, 2, 3 on the top, then 4, 5, 6, kind of making a whole circle here. But you have your endodontic access, of course, finding canals, orifice openers, scout files. Then we're going to do what we like to call coronal conditioning, and that's a low frequency energy using tip 2, and in that case we're using the 20 millijoules, 0.4/20. Air and water is 0, and we're using continuous irrigation. And my rate of delivery of the continuous irrigation is 5 mLs per minute, which works out to be about roughly, if you're using 3 ml syringes or 6 ml syringes, let's say you're using the 3 ml, then you'd roughly go through your 3 mLs or so, almost 2.5 to 3 mLs in 30 seconds. That may be a round of coronal conditioning as you're looking for your orifices and you're starting to instrument the canals. You may do another round of this as well. Um, and then you start with your instrumentation. I want to emphasize mechanical tissue removal. While the laser can be very effective at removing tissue, it's going to take a lot longer to remove the bulk of that tissue initially. So I like to think of the laser as doing the final little smaller bits that you can't get with a file. And I like to do the original initial instrumentation with files and the initial tissue removal with files. And in this case, I'm using NiTi files. XP shapers are great in that they touch more surfaces within the canal and can really remove some tissues that you thought were all removed already. The XP shapers allow this more efficiently, in my opinion. I also use the K files and Hedstrom files in larger canals. Um, Okay, so we're doing some instrumentation, and then we're going to bring this back to syringe and continuous irrigation, as you saw in some of the videos. We're going to continue to use 3 to 4% hypochlorite, and go back and forth between 3 and 4, and more rounds of continuous irrigation. Um, in this using that 30 seconds essentially. At this point, you could put maybe tip 2, maybe in the orifice or mid-root as you're doing this until you achieve your instrumentation completed. At that point, we are going to go to switch over to what I like to do is um, syringe irrigation with intermittent irrigation. And we're going to be using Triton all-in-one solution or irrigant. And we're going to switch over to high frequency at this point, keeping our millijoules the same at 20. We're just going to go from, we're going to increase the hertz to 40 as opposed to 20. In this case, you may be doing 10 seconds per canal, and you may repeat this 2 or 3 times. I may then, of course, do syringe with more Triton to remove some of the perhaps tissues that I thought were gone, that there might still be some there. And then we're going to continue on with uh, a cone trine at the end and some gentle MDA, manual digital agitation. And we're going to modify, if needed, the canal prep in case my cones don't go to length. And in this case, it's just usually a simple file that just goes to length like I'm using to recapitulate. And then following that, we'll do what I like to do at the end is a final rinse with saline. This means my cones fit down the length where I want them. I'm done with instrumentation, and I just kind of want to get all the chemicals out of the tooth. In this case, I'll switch to saline, and I will go back to a low frequency. Same energy, 20 millijoules. In some cases, I may up the energy to say 25 millijoules or even maybe 30 millijoules and just deliver one last final rinse of the whole system. And I'd like to do this continuously, usually with tip 2, just to get a little bit more power in there. And I do like to just keep the tip in the orifice at this point. I don't usually go mid-root here, just keep it in the orifice because we're dealing with a little higher energy. And then we're going to use our microsuction at the end of that. And then we're going to apply our BC sealer high flow in the single cone technique, just as shown in the previous case of the middle mesial canals. Just unpacking that a little bit, we start with continuous irrigation. We're choosing the low frequency, 20 millijoules, 0.4 watts over 20, air and water 0. We're going to do our instrumentation 20 to 30 seconds each time that we do this. That's about 3 mLs worth of the hypochlorite solution. You're going to instrument. Here's the files I like to use. I've included also edge files here, the N2 and X7 series, and of course the Brasser USA, XP4D and XP3D. And here again is sort of that emphasis on continuous irrigation for the instrumentation phase of treatment, and then we'll go to the disinfection phase of treatment with the intermittent in just a sec. But this is kind of that first sort of coronal conditioning to instrumentation phases where we're mostly using continuous irrigation. Okay, so we're getting close to instrumentation being completed. We're still using solutions of 3 to 4% hypochlorite. We're still using the low frequency. Now we're going to complete instrumentation, and we're going to move on to a syringe and intermittent irrigation. We're going to switch to solutions like Triton, for example, if you choose. I do prefer it. Or you may do your EDTA here, followed by your hypochlorite, again here at this point. And in this case, what I'm recommending is, and again, this is kind of my opinion on it, but I do feel that there may be some benefits to this at this point in time, but I'm recommending that higher frequency setting, keeping the energy the same because it worked for us initially. We're going to go to a 0.8 watts over 40. All you need to do on the EdgePro is go from 20 hertz to 40 hertz. The watts will self-adjust themselves. And in this case, you've entered what I call the disinfection phase. And this is more of that chemical irrigation piece. So we've done the mechanical. This is the chemical. Towards the end here, we're going to do our cone try-in, the gentle MDA, and modify if needed. And I may have mentioned before, but in this case, we do have a little bit of increased temperature in the solution as we're doing it in an intermittent way. And this is beneficial in my opinion. We're going to follow that with a final rinse of saline. And then we're going to go back to our continuous irrigation and go back to our low frequency setting of the 0.4 over 20. So in that case, all you do on your EdgePro is just dial down the hertz from 40 to 20. Okay, so here's a here's a case that I did very recently for this using this protocol. It was a tough, long-rooted four canals, two mesials that were joining at the apical with clearly some isthmus potential there towards the apical region as listed on those studies. And the distals, well, we had two separate canals, as you can tell here. We did it one visit. We used tip 2 with all what I mentioned in the protocol. You can see here on their pre-op CBCTs the challenge that we were up against. And then you can see here on our PAs, I don't have a post-op CBCT on this case. I don't routinely do this, but you can tell on the post-op image, the PA towards the bottom here, you can tell on this shift X-ray where we cut off the distal root, you can tell that there's a confluence there at the apical region where I feel pretty confident that I did clean very effectively that isthmus using this technique and the laser tips used. Of course, just a reminder, we did use that final rinse of saline continuous irrigation tip 2 at the lower frequency, and that's the case there. We're going to do another case where we do continuous hypochlorite, then intermittent, and then a final rinse as well at the end with the saline. And in this case, we had a necrotic case. Patient was actually acute apical abscess, had a buccal swelling. I did complete this in one visit. I also did an IND procedure with laser at the same time on the buccal aspect with a fluctuant area. It was pretty simple to do. In this case, we have a mesials that are joining slightly at the apex, and we have in this case just one distal canal. You can tell again that on the CBCT pre-op that in certain cases, yes, there's an isthmus there, and it's probably going to be challenging to clean all that. But I think, again, with lasers, we have at least a chance. And as we improve our protocols and do more studies, I think we can eventually get there one day where we can effectively clean these accessories and anastomoses and isthmuses at one point in time. And just a reminder again, I like to do that final rinse of saline, continuous irrigation, tip 2. I like tip 2 in these cases because it's just a little bit more power. Can you do it with tip 1? Yes, you can, but you may have to increase the energy a little bit to overcome that 55% calibration factor. So here I'll leave you. This is my last case. I'll leave you with this. So this is a case I did about 4 years ago. This case is actually my father-in-law, and this is when I was relatively new at laser, but already you can see that I felt the confidence was there, and I, did this treatment for him. He complained of some pain on that tooth number 20, 5. And so we did this case one visit. He was in from Peru, and I was confident on my diagnosis, and I isolated it to be just that tooth number 25, even though we had a periapical lucency on 24 at the apex. I was quite confident, and so only treated that tooth in one visit. And these were the immediate post-op images. Well, he was in just this past October, which is just about 4 years ago. Sorry, which represents 4 years when I treated this case. And he said to me at dinner, he said, I feel this lump on the lingual aspect of the front of my front mandibular teeth. And I said, oh man, I wonder if it's if it's the tooth I treated. I looked in the mouth at the dinner table and I could see a quite significant fluctuant swelling on the lingual of this tooth, and what also looked like maybe a little sinus tract coming out of it. And I went to the office the next day, and I was expecting to come in later in the day. And I was looking at the previous x-rays and I said, wow, maybe the tooth didn't work out. Maybe the treatment didn't work out initially. Maybe I misdiagnosed it and the adjacent tooth needed also treatment. And now the lesion's going to be way bigger than what it was. And we took the x-ray, and I was pleasantly surprised to see amazing bone healing. And what it turned out to be was a periodontal abscess. So I'm glad that all that worked out. And just to keep your faith going, and just to show you that root canals do work out really well, and that you have to take your time, obviously. And I think newer technologies, as we implement them, including lasers and better irrigation techniques, I think can really help us out to do better and more predictable treatment. By the way, I did use a laser on him, but just in the sulcus and of that tooth in the lingual, and haven't heard since. So no news is good news. Laser's great for periodontal lesions as well, and acute sort of periodontal abscesses too. So thank you very much. It's been a
Thank you.
pleasure. Mhm.
Thank you, Dr. Meza. There's some questions coming in, but before I get to those, I'd like to again invite viewers to use the chat box on the right side of your screen to ask any questions that you have. First question coming in: what is meant by the chemomechanical root canal preparation in terms of laser activated irrigation?
Yeah, so I think what we talked about a lot today is how we can use solutions, and those by I guess inherently are chemical reactions as they interact with tissue and necrotic debris and bacteria. And what we're doing here is we're using laser to make them more efficient or make them more effective. And this is done for sure with intermittent irrigation. As the increased temperature of the solution within the tooth rises, then it makes the solution more effective. So um, the mechanical part is, of course, our files, and we've always been using some sort of a solution, but now we're using a laser to agitate that solution, and it's becoming even more effective. We're adding that turbulence to the solution that maybe wasn't there. And that's why I like to think of this in terms of integrating it with laser activated irrigation.
Okay, next question. What is the approximate speed of fluid motion for ultrasonic activated irrigation and laser activated irrigation?
Yeah, so as we saw in that slide, uh, essentially, ultrasonics has limited cavitation effect in the tooth. I know previous studies can show robust cavitation, but that might be a big reservoir or a larger prepared tooth. It certainly has streaming in the tooth, but as some of these studies have come through recently, the streaming, as they've measured the fluid velocities, the streaming for ultrasonic activated irrigation, particularly in areas of lateral canals, drops down to closer to the 0.33 meters per second, which is almost barely even 1 mile per hour. And I had done in that slide, I had shown basically that it's like somebody very, very slowly walking, versus laser active irrigation. You're going about 22 times faster fluid flow, and you're getting the robust cavitation effect. And so that's what lasers can do for us in the tooth, where ultrasonic units cannot. And so I think we're just moving into a new era or a new level of essentially using lasers to activate or enhance irrigation to have it be better, basically.
Okay, what is the difference between passive ultrasonic irrigation and continuous ultrasonic irrigation?
Yeah, so this is a term that was used in ultrasonic irrigation, and that's essentially what it was trying to show is that water either is coming through the unit. This can also be applied to lasers where you have water going through the unit in the handpiece, and those would be an example of continuous irrigation. You can also have the dental assistant usually deliver continuous irrigation for you, unless you're doing a mandibular tooth and you got rid of your hand mirror. You can also do continuous irrigation holding the solution in one hand and then and then the laser handpiece in the other, but then who's going to be doing the suction? So it becomes difficult to do this in this way. The pass the so that's The passive ultrasonic irrigation is similar to the intermittent irrigation where you're flooding the chamber first. There's no suction, and then you're applying the laser handpiece or an ultrasonic unit in the chamber itself or the canal itself, and you're agitating the solution. And of course, then you got to bring your syringe to, flood that out and suction it to because all of the tissues that you disturbed, you want to get rid of those and you want to flush them out. So it's a back and forth of syringe irrigation, agitating within the canal, and then suctioning that out and repeating it all over again, as opposed to the continuous, which is kind of all happening all at once.
Okay, does cavitation occur during sonic activation of endodontic irrigants?
So no, this kind of not result in any connection and cavitation. There's usually a vapor bubble, or there's a large bubble that when it implodes, it creates pressure waves and allows fluid to rush down into a barrier like the wall, the canal wall, where you may then have secondary cavitation forces, which again which are more bubbles that collapse or implode, and you have jets running through them to create pressures. And so this action of initial vapor bubbles or bubbles being created by energy unleashed onto a fluid um, can only really happen with ultrasonics, with high frequencies, vibrations, or with lasers, but it doesn't happen with sonic oscillating instruments. You have to have a much higher frequency or power or energy, like you do with laser.
Okay, what is the breath mode in laser activated irrigation?
Yeah, so that's in recent studies again showing fluid flow within lateral canals and the main canal. Essentially, it's for the first time they're showing fluid flow that can come into a lateral canal and then come out of the lateral canal, where that may be what's typified as maybe the breath, like inhaling and exhaling as it goes in and out of the lateral canal. So it's a complex fluid motion that's occurring within within lateral canals or maybe isthmuses, as we try to understand how the fluid dynamics occur inside a tooth with accessory canals and isthmuses. And so I think the more we learn about this and the more we discuss enhanced irrigation and, of course, lasers, I think we'll be better understanding of the fluid dynamics that are occurring. And then if we understand it better, we can then make the right moves to make it more effective for us in clearing our debris and disinfecting these what I called the last frontier here in the tooth, the dentinal tubules, the lateral canals, the other accessory canals, and the isthmuses.
Is a radiographically filled lateral canal evidence that is thoroughly cleaned or disinfected?
Unfortunately not. It's been shown by histology that you could still have inflamed tissue within a filled canal. Could also have presence of bacteria within the filled canal. So these are examples of entombment, basically. And what we're aiming here to do is to get rid of the bacteria and rid of the tissue that's inflamed in the lateral canal, if that's even possible. And my belief is that as we learn more about laser activated irrigation and use lasers as a potential source for tackling these lateral canals and trying to get them as clean as possible, I think it may be possible one day to clean them better and disinfect them better. And then at that point, hopefully, when they're filled without these remnants being left inside and just filled more. They're just filled better, basically, at that point. And hopefully, that will lead to fewer failures of cases because a lot of times you get the false impression on the X-ray just because you see a filled canal that maybe there isn't tissue there or bacteria in there. And if you get a failure of the sealer by way of some kind of resorption of the sealer, or it gets dissolved away, then you may create a space. And if there's any kind of bacteria lingering in there or inflamed tissue causing further inflammation and pain, then you can get exacerbation of our apical periodontitis and ultimately a failure of the case and having the patient have to return for either an apicoectomy or retreatment or even extraction of the tooth.
Okay, what is meant by bulk debridement and disinfection compared to deep debridement and disinfection?
Yeah, so this was in a slide, and I like to always sort of focus on the slide and other presentations I've given too. And this is essentially how I like to think of the three phases of treatment and how I like to think of that last frontier, which is the dentinal tubules. But bulk, to me, bulk debridement is essentially what you need to get out first before you go before you can tackle or gain access to these dentinal tubules. And so you've got to remove the tissue, the necrotic debris, the main canal, of course. And then once we've done this, then we're entering into what I like to think of as the deep debridement. Now that you've gotten rid of these things, you can allow fluid to be agitated with lasers to then go into to start to work at the entrance of these isthmuses and the entrance of these lateral canals and dentinal tubules so that we can enter into this last phase of disinfection, which I think till now we haven't really put that much importance, or well, we've tried to put importance to it. Obviously, we knew about it, but maybe we just didn't have the tools to be able to do anything with it. But now I think with lasers, it really offers a lot of hope to try to clean these deep areas in the tooth.
Okay, our last question. What are some of the differences felt in the photoacoustic effect in fluids in the chamber and canal when keeping the average power or energy the same, such as 0.50 watts, 25 hertz, or 20 millijoules compared to 1 watt, 50 hertz, or 20 millijoules?
Yeah, so that's what I tried to show with that study with the tooth in the hand is that it's a really simple experiment that you can try at home with your laser, in between patients or maybe early in the day. And what you can do is you just make sure it's plugged up correctly on the apices because sometimes these teeth, natural teeth, they may leak at the apex. So plug that up with some glass ionomer or composite resin or cavet, what have you, and then flood the chamber. Make sure the chamber stays flooded, and then try that equivalent energy of 20 millijoules, for example, and like you're saying in this one, and then just feel with your fingertips as you're holding the tooth, the pounding and the pulsatile nature of the lower hertz condition, and that can be at the 20 hertz or 25 hertz, and then switch over to the same exact energy output, except that you're now changing the hertz to 50, essentially doubling the hertz. So that means you're doubling the number of pulses per second. And what ends up happening is that you have a much gentler sensation that's more sustained pressure. Um, and what I like to, I also gave an analogy of boxing where you have little jabs versus deep uppercuts, and the little jabs represent the higher hertz and the gentler sustained pressures as you'll feel them in your fingertips compared to the lower frequency, deeper uppercuts. So I like to just to say this because I do believe there's some benefits to when and how we apply these different modes of energy and hertz within the tooth. And I think they could make a difference in protocols. And I think more needs to be done on it to study it. But I like to, go back to first establish your energy and then decide what your low frequency is going to be, and then keep your energy equivalent. And then you decide what then you just move up to the higher frequency. And I think that they're beneficial settings to know and use.
Okay, well, thank you everyone for your questions, but we've run out of time today. If we did not get to your question, we will answer it after the webinar via email. In 1 hour, we will send you a link to the replay of this presentation and the link to access the CE quiz. Please be sure to complete the free CE quiz associated with this webinar to receive your continuing education credit. Thank you all again for attending, and a special thank you to Dr. Fernando Meza and our sponsor for this webinar, Bachelor USA. Thank you and have a good evening.